Hello, everybody. I'm Dr. Steve Edelman. Welcome to one of our new programs for 2025 called TCOYD Live Q&A. I'm an endocrinologist at UCSD. I think you know me pretty well if you've watched our programs. And this is Dr. Tricia Santos, who's also an endocrinologist at UCSD, did her training under moi, along with Dr. Pettis, who's not here today. And we're here to answer any questions you have about any topic at all. There's no rules. There's nothing that's off limits. Tricia, you want to say hi?
Yeah. Hi, everyone. Thanks for having me today, Steve. I'm excited to be here. You taught me everything I know, so hopefully I have something else to contribute here, but excited to do this.
Yeah, that's awesome. It's also important for you to know, if you're new, we have a lot of great content on our website, but on all the social media channels, Instagram, Facebook, YouTube. We got a podcast. We have lots of information. We have a video vault with all different topics. Today, we're doing any questions regarding type 2 diabetes. The last time we did this, we did for type 1, and our next one's going to be for type 1 diabetes. And so make sure you like us, you follow us, you tell your friends about us, and we hope you enjoy this next hour or so. We're going to get through all the questions as best we can. The more questions we have, probably the faster we'll answer them. And so let's start, Tricia.
All right, let's get started. You know, I'm looking at the live feed of questions here, and I'm already seeing a lot of questions about the GLP-1 medications. And I think we should start there. This is really kind of where it's at for type 2 diabetes. So one of the first questions is, I just started Ozempic and it really upsets my stomach. Any suggestions? So I guess maybe we'll back up and just say, Ozempic is kind of one of these GLP-1 medications. Other ones are Trulicity or Mounjaro. These are once a week injections. And actually, nausea is probably the most common side effect with these medications. So it's a good one to talk about.
Yeah, I should say there's some awesome video content we just did comparing all the different medications. And I think you're right. There's so many questions about this class, maybe a slight primer on it right now. As you all know, Ozempic is a GLP-1, one of the most popular ones. If the doctor prescribes it for weight loss, it's called Wegovy, same exact medication, but you can get it in slightly higher doses. With Mounjaro, if they prescribe it for being overweight, it's called Zepbound, same exact drug. Don't ask us why they do that, but it is pretty confusing. Yeah. And one of the first ones out, I would say one of the first ones was Victoza, once a day, and then it went to Bydureon, which is once a week, and then of course Trulicity was once a week, and now we have the newer once a week products. And I think the other thing I want to say to everyone is, and we'll probably have a chance to repeat this because it's so important. These drugs not only help with weight loss and improve your diabetes control, they have been shown to protect your heart, your kidneys, prevent fatty liver, even people that have obstructive sleep apnea, osteoarthritis in the knees. I mean, the list goes on and on.
So people with alcohol use disorder or other kind of, addictive disorders, it's been shown to be helpful there too.
That's why Jeremy takes it. Okay, well, let's go for
the nausea.
The nausea, it's such a great question. Thank you.
It's a really good question. And because these medications can cause nausea, that's why we start them at a very low dose. And one thing I will say is some people get a little frustrated because when you start this low dose, they feel like it's not doing anything. Some people, it does something right off the bat, but in a lot of people, they feel like it's not doing anything. I would say be patient. We have to start those low doses because that allows people to kind of tolerate them a little bit better. But what I'll say is the reason that these medications cause nausea is because they slow down your stomach from emptying. So food sits in the stomach a little bit longer, and that can make people feel nauseous. So it kind of makes sense that one of the things that we can do to kind of decrease the nausea is eat smaller meals, actually. So it turns out on these medications, a lot of the times that the people get nausea, a lot of times when people get nauseous is when they eat kind of a larger meal or maybe one of the meals that they're used to eating. I always tell my patients when you start these medications, it's better to eat kind of smaller, more frequent meals rather than kind of, 2 or 3 big, large meals a day. That's really going to contribute to the nausea.
Yeah, that I can add to that answer a little bit. Now, the Ozempic pen, the starting dose is 0.25. And that's about 20 or 30 clicks. And I tell most of my patients, Tricia, don't start with that dose. Count the number of clicks up to the starting dose. Then you can go backwards back to zero and take half that dose once a week for a couple weeks. If there's no nausea, then you can go up to the full 0.25. Most of the nausea occurs when you first start these medications. And that is a very good trick as well. There's no rush.
Yeah.
You haven't been on this drug your whole life, I presume, and you want to take it slow. You don't want to have any side effects. And it's interesting. Some of our patients don't have any at all starting at the regular dose, starting dose. With Monjaro or Zepbound, they're saying they're auto injector pens. Starting dose is 2.5, and it's all or none, and you can't titrate it. But I don't know about you, Trish. Most of the patients I start on Monjaro, they do pretty well in terms of nausea.
Yeah, and I think Manjaro actually has been shown to cause a little less nausea than some of the other GLP-1s. Although I have to say, it really is just some patients get it, some patients don't. And so, it's worth it to, if you are able to kind of stick with it. The nausea, actually, your body kind of it starts to tolerate the medication the longer that you're on it. And the other thing I'll say about nausea is, so if you're having nausea, even at that lower doses, the best way to handle it and to kind of get your body used to it is to maybe even stay on the lower dose longer than 1 month, which is kind of the typical time when we start increasing the dose. Staying on it longer allows your body to get used to it. And some people just have to go at a different pace than others.
Yeah, it's really variable. Now, Monjaro or Zepbound, it's not just a GLP-1, it's a GLP-1 and GIP agonist. And if we described what those stand for, you would probably look like a deer at headlights. However, some people hypothesize that it's the GIP part of the dual hormone agonist that may help explain not only why you get bigger A1C drops and weight loss, but also GI side effects. But nonetheless, they're both excellent drugs and they work a little bit differently. And it's hard to predict who's going to get side effects or not.
For sure. Okay, I want to stay on this topic since we're on it, of the GLP-1s. There's a question here that says, is the oral GLP-1 just as effective? So we actually, as I mentioned before, these GLP-1 medications are once a week injections, the vast majority of them. The semaglutide, which is the medication in Ozempic, actually comes in a pill form as well. We don't use it quite as often,
Right.
but there's a question here. What do you think, Steve, about it being effective?
Yeah. Well, it's interesting. Endocrinologists, we've stuck to the injections once a week, and I know Jeremy and I have had that conversation. We would rather just take an auto injector once a week than take a pill every day. The pill has some instructions where you have to drink a third of a cup of water and then wait couple hours before you eat. It's not that bad, but it won't work well unless you follow those instructions carefully. And the data on it looks really good. And it was just approved for cardiovascular safety as well. And I would say primary care doctors tend to use these more because they are afraid of injections more than you guys are. And they don't want to teach it. They don't have time to teach it. And it does work well. And I've had a couple patients request it. They didn't want the injections and they did quite well.
Yeah, I think so. And I think, with some of these medications, the once a week ones, they are coming out with higher and higher doses now. And so some of those kind of extra high doses of these medications may be more effective in terms of blood sugar control and weight loss. But yeah, the oral meds work pretty well. And I would say if just get on one if you can. I mean, that's the main thing.
And it's also interesting that Lilly is developing an oral GLP-1 as well. It's not available yet, but it's in studies, and you'll have your choice of different oral medications or injectables. And Tricia's right. They're studying higher and higher doses. Like Ozempic just got approved, I think 7.2 milligrams a week, and the maximum now is 2.4. And
Wild.
yeah. And Jeremy said, you could lose 100% of your body weight. That means you're going to disappear. All right.
Okay, there's another question here about a GLP-1 that says, does Manjaro help you lose weight? I've been on it for over a year and I've lost no weight. And this can be really frustrating because I think these GLP-1s, they promise a lot. A lot of the studies actually have shown that the GLP-1 medications, those injectables, once a week at the highest doses, are causing weight loss similar to bariatric surgery. It's really incredible. But we do see this sometimes where patients, the amount of weight that patients are losing or the amount of blood sugar control that they're getting with these medications can be highly variable. One thing I do see, if you're not losing weight on these medicines or if you're not getting good, blood sugar control, I often see people forget to increase the medications. So this is not like, other medications you may be on where you stay on the same dose the second you get on it. These medications have to kind of be titrated or increased every single month. And that's something that people can lose track of.
Yeah. Well, Tricia, I'll be honest. I've never had a patient who went on Ozempic and did not lose any weight. I've had some that lose a little bit. So a couple things. I did have a patient that went on Ozempic and didn't lose any weight. And the question I had for her was, where'd you get it? It was a compounding.
Yeah, that's a good point.
And it was just fake Ozempic that she paid for. Now, the other thing I want to mention, this is a little complicated, but there's a condition, ready for this, called hypercortisolism. And we did a program on that, and you can check it out on our TCOID website. And this is a condition where your body produces excess steroids. And it's a condition where people do not respond to diabetes drugs well. They don't respond to blood pressure pills very well. And the one patient I had with this, they did not respond to a GLP-1. That's probably a little bit more on the unusual side. Yeah. But I would say make sure you're taking the real stuff.
For sure. Actually, I think that's a really important point, Steve. And the FDA has come out with recommendations now against getting these medications from compounding pharmacies. I think it seems like a really sexy option because sometimes they're more affordable, coming from compounding pharmacies, et cetera. But the coverage is getting a lot better by insurance. And when they're in those compounded pharmacies, the problem is we don't know what's in them. We don't know how much is GLP-1, how much is something else. We just don't know.
Yeah. And last thing I'll say on this topic is for people who don't respond as well as they like on the maximum dose of Ozempic, then we try switching to Mounjaro or Zepbound, whichever one we can get. Having type 2 diabetes, you're lucky because you can get either one because they're officially approved for type 2s. When we did this same live Q&A for type 1s, we have to go through a bunch of tricks to try to get it approved, mainly focusing in on obesity, never mentioning the word diabetes. But that's if you have any type 1 friends.
Yeah. And you actually answered one of the other questions here, which is there any benefit to switching between one or the other? So what you mentioned was, sometimes if there's a higher dose available in another GLP-1, that might be a reason to switch. In general, just getting on one of these medications is one of the best things you can do for yourself in terms of your health and your diabetes. And it doesn't matter too much what one. Most of the time that we're prescribing these, it's actually just whichever one the insurance is going to approve.
Yeah.
To be honest.
Yeah.
And they all work great. They all have, the same benefits for the most part. So, don't worry too much if, you can be on one and not the other.
Yeah. Well, I think now might be a good time to go to a video question that someone sent in, but also for the rest of you, you can ask a question right now on the live feed. And so we can answer it. So it's not too late. And Eric, why don't you play the first question?
Hello, my favorite endos. This is Chef Robert Lewis, the happy diabetic. My question is an insulin pump for managing my type 2 diabetes right for me? I use mealtime insulin daily. So how would it compare to multiple daily injections in terms of control and convenience? Thanks for all you do. And remember this, no one loves
you. Eric, we could not hear that question. I don't know if you can paraphrase it for us or play it again.
We'll play it one more time.
Okay. All right.
Hello, my favorite endos. This is Chef Robert Lewis, the happy diabetic. My question is an insulin pump for managing my type 2 diabetes right for me? I use mealtime insulin daily. So how would it compare to multiple daily injections in terms of control and convenience? Thanks for all you do, and remember this, no one loves you.
Well, that's a good question. I think,
Should paraphrase that.
yeah.
too.
So, the question was really how can an insulin pump or can an insulin pump help someone with type 2 diabetes? And I think, back in the day, we really only used insulin pumps in people with type 1 diabetes. And nowadays, the insulin pumps are getting so sophisticated and a lot easier to use. And I think there is a lot of room for using insulin pumps in type 2 diabetes.
Yeah, it turns out that when you look at the different hybrid closed loop systems, especially the ones that have been on the market for a while, we know that the Omnipod 5 and the Tandem Control IQ is approved for people with type 2, but you can pretty much use any of them. And when Jeremy and I went to Amsterdam and we did a summary of it, that's also on our website, that so much data now is on type 2 diabetes. Why not? If you're on multiple daily injections, and making these decisions yourself, why not go on a system where the CGM communicates with the CGM communicates with the pump, gives you automatic insulin delivery. And trust me, these systems make way better decisions than you or me. And so it's not a bad idea. Like how would you describe a perfect candidate for it if someone's listening now?
Yeah. I just want to back up a little bit because you use that term hybrid closed loop and just explain what it is
Yeah.
in the type 2 world. So, an insulin pump is just a device that holds insulin. And sometimes it's a device that kind of has some tubing connected to your body. Sometimes it's a device that you wear on your body like a patch. And that pump will deliver insulin under the skin, basically while you're wearing it. And what we mean when we say hybrid closed loops or these smart pumps that we have now is the pump talks to the continuous glucose monitor and helps adjust the insulin for you. So really the people with type 2 diabetes that we think are good candidates for this type of therapy now are someone who's already on a bunch of insulin injections. So this would be somebody who's taking, 3-4 injections of insulin or even more a day. These pumps can simplify your life. It, can decrease the number of injections that you're having to do per day. You still have to tell most of them when you're eating and kind of what you're eating and make some decisions about that. But the other reason to go on a pump is for people that are on quite a bit of insulin, it actually can be a safer situation because these pumps, because they talk to the continuous glucose monitors, they can actually adjust the insulin for you, shut it off if you need to, in the middle of the night instead of having a low blood sugar. And I think safety, in addition to, controlling the blood sugar, is a really important feature.
Yeah. No, thank you for that. I think the other individual that do well, if let's say you're on one shot a day of long acting insulin, Lantus or Tricia, and you're taking pills during the day and your control is terrible. We know you're going to need fast acting insulin with meals, and converting to one of these hybrid closed loop systems that Tricia explained, it can really make life easy. And the other thing that I've noticed when you take someone on a bunch of injections, someone with type 2, you guys use quite a bit of insulin compared to type 1s. When you go onto a more physiologic system, like one of these hybrid closed loop systems, they use a lot less insulin. And that does help with any potential weight gain that you may get. If your control is terrible and your A1C is high, you're probably going to gain some weight as your A1C comes down. But nonetheless, it's a small price to pay for a much healthier state. And there's no reason why you can't be on a GLP-1 drug plus one of these insulin pumps that communicate with a CGM. So it's something to consider. And once again, we have some really good content on our website.
Yeah, agree. And I think it's going to be the wave of the future. I mean, really. Along the lines of kind of technology, there's a question here that says, will they ever make CGMs for type 2 non-insulin people with diabetes that insurance will cover? So
that's the key part.
Yeah. So, these continuous glucose monitors are really getting more mainstream now. We've been using them in people with type 2 diabetes for many, many years. And traditionally, a lot of the insurance companies will only cover them if you're on insulin. Now, there are a few ways around this.
Yeah,
I mean,
yeah, I'm thinking too. I hope the FDA is not watching
I
this
know,
show.
exactly. So a little trick I learned from Steve back in my training was to prescribe a small dose of insulin. I mean, you can even do it as needed when the blood sugar is over 500 or something. That's what you used to teach me. So that there's insulin on there and the insurance company sees that you're on insulin, and that may help you get it approved. And sometimes it feels a little snaky to play games like that, but honestly, I feel like they play games with us, and sometimes we have to play games right back. So
Yeah. She learned
Yeah.
well. I was thinking the same thing when I saw that little smirk on her face.
yeah,
You can ask your doctor that, listen, sometimes my blood sugars pop up to above 200. I'd like some fast acting insulin to take care of that, or one shot of long acting insulin a day. And it could be 5 units, and you don't even have to take it unless you really need it. And once you're on one shot a day, you're eligible. And I agree with Tricia that these devices are helpful for everybody. Even people on pre-diabetes can see what happens when what they eat, how much they eat, or their exercise regimen. And I think it is going to be the wave of the future. And I think everyone's going to be eligible. You can buy it over the counter.
yeah,
But they're not cheap either over the counter.
no,
If I was going to buy it, I would not buy the one over the counter. I'd ask my doctor for a prescription and just pay cash for it, because they're a little bit more sophisticated and they have more bells and whistles. But if you don't want any, that's
and
fine
to be
too.
honest, some of the ones that are prescription, honestly, if you buy them out of pocket at the pharmacy, the cost is not that different
Right.
than the ones that don't require prescription. So that's a really good idea. There was a quick question here along the lines of CGM is, now we have the Libre 2 and 3 Plus systems. It's getting confusing with all these different name changes.
It's like Apple Plus, Disney Plus, Platinum Plus.
And this person was asking if there's any benefits to being on the Plus. My understanding of the Plus is that there's not necessarily significant benefits. It's the new system that it's all going to right now. But in terms of accuracy and how well they work, my understanding is it's the same.
Yeah, I agree. The Plus, I believe, is meant for the CGMs that hook up to insulin pumps. No,
I think now everything's moving over, but I could be wrong.
No, everything is moving over.
Yeah. Okay.
Yeah. And I don't think there's any difference.
Yeah.
Have you heard about TCOID Plus?
No, but I'm looking forward to it.
No, I haven't either. So you never know. If we have a good creative team here, they might come up with that. Maybe the second video.
Yeah, let's do it.
Hi, Dr. Edelman and Dr. Santos. This is Linda from San Diego. Here is my question. I've lost a lot of weight on Ozempic. I feel great, and I'm ready to go off of it and see if I can do it on my own. Everyone tells me you can do it if you try hard, but doctors tell me I'll gain the weight back.
Gosh,
well, we're doctors, so you're going to gain the weight back. No, we'll give you a better explanation. Please, go first.
I'm so glad you asked that question, because this is such an important topic. And I think that this really goes back to thinking, when we're talking about weight loss, thinking about obesity as a disease. And I think, obesity is not just a lifestyle choice. It's actually a genetic disease that we know about. And when you think about other diseases, high blood pressure, high cholesterol, we don't typically put patients on medication and then start to stop the medication once everything looks better, because then the blood pressure would go high again, et cetera. And it turns out when we look at all the studies of patients that have been on these medications and when they stop, most patients will regain a significant amount of the weight, if not all of the weight, back when they stop these medications. These medications certainly do teach patients kind of a lot about portion control, about how to eat, differently. And so they can really trick you into thinking, I've got it.
Mm-hmm.
But I think one of the things, you mentioned kind of what people are saying and what doctors are saying. And one of the things that doctors know about is that I think everyone isn't aware of, is that these medications actually change a lot of kind of hormones and other things in your brain. that help you kind of curb your appetite and help you eat less. And as soon as the medication is out of your system, that help is gone.
Yeah.
And so even if you feel like you can do it, I don't want to discourage anyone, but even if you can feel like you can do it, it is very hard to maintain the weight loss.
I want to discourage everyone because there's a couple things. Tricia mentioned this study, and they've done it with Mounjaro and they've done it with Ozempic. I mean, a really official study where 200 people go on the drug, they all lose a lot of weight. Then at one point in time, half of them go on a fake placebo, the other half continue. And the people know that they may be going off. They don't know for sure because it's a blinded study. And Tricia's right. Most of the people where they got placebo gained most of the weight back. Now, the other thing I'd like to tell you is that this is a drug that not just helps with weight and diabetes. As I mentioned earlier, this is a drug that helps reduce cardiovascular disease, helps reduce the progression of diabetic kidney disease. It helps reduce a condition called fatty liver that can lead to cirrhosis and liver transplantation. So this is a drug that I tell patients, you want to be on this drug the rest of your life. And the last thing I'll say is that when you lose weight on any of these drugs, you lose a certain amount of muscle, which is physiologic because you don't need as much muscle to carry around a lighter body. And you lose fat, mostly fat. But if you yo-yo, you go off the drug and you gain weight back, guess what? Most of that weight is fat. So you yo-yo, you're losing muscle each time, and then you're gaining back mostly fat. So it's so important that when someone makes a commitment to go on these drugs, that it's a lifelong therapy. And I wouldn't listen to any of your friends ever again.
All right. Switching gears a little bit here. This question says, what can I do about worsening kidney disease caused in part by type 2 diabetes? Any ideas to slow the progression or dietary recommendations?
Wow. Let me just say, we did an awesome videos on that on our website, but you go first and I'll fill in if you forget anything.
Yeah. I mean, so kidney problems are a very common complication of people living with diabetes. And actually, kidney disease or low kidney function, the most common cause of that is diabetes and high blood pressure. So this is very, very common. So what I would say right now, the biggest thing that I would recommend, being, not being a kidney expert, but being an expert on the diabetes side, is that we have medications, 2 different classes now of medications for type 2 diabetes that have been proven to slow the progression of diabetic kidney disease, regardless of what they do to the blood sugar. And I think this is really a shift in the way that we're thinking about complications about diabetes. So I'll kind of start with one of the classes of medications is the GLP-1s, which we've been talking about a lot already today. Those once weekly injections, most of them, they are showing benefit in terms of slowing the progression of kidney disease. So they protect your kidneys. The second class of medications is the SGLT2 inhibitors. It's always a mouthful, all these diabetes medications. But the SGLT2 inhibitors are a once-a-day pill. And those medications, honestly, they have a little bit of, they help a little bit with the blood sugars, but truly they've almost morphed into more of a kidney medication now than a blood sugar medication. So these medications drastically slow the progression of kidney disease.
We should name them.
Yeah. So these medications are, Jardiance, Farxiga, Invokana are the ones that help with the kidneys. So that's probably 2 of the best things that you can do is get on these medications. And one thing I'll say is that our guidelines now from the American Diabetes Association say that even if your blood sugar control is perfect, even if your A1C is a goal, even if everything looks great, if you have heart or kidney disease, you should be on these 2 classes of medication, SGLT2s and the GLP-1s.
Yeah, that is so important because even drugs like Farxiga and Jardiance, they've been shown to reduce congestive heart failure, which is also another important side effect in people with diabetes. So there's the baseline protection, glucose control, blood pressure control, and then use of a blood pressure medication called an ACE or an ARB, and they've been around for a long time. Then we got SGLT2s. We now have GLP-1s, and there's one more we should mention, which is, ready for this, a mineralocorticoid receptor antagonist, Corindia, Kerendia.
Oh, I'm impressed that you can spell that.
I looked it up before the show, and because I'm a terrible speller. And that is a medication specifically studied in people with type 2 who have pretty advanced kidney disease, clearly showed protection. And when I listened to some of the medical lectures on what they call the pillars of therapy to prevent the progression of diabetic kidney disease, it's those three classes. Corindia is the newest, and you could use them together. And if I had kidney disease, which I do, I would take all the ones my doctor suggested. So I'm on all of those except Corindia. And I'm waiting, my kidney function's stable. And that's something to have in the back pocket if my kidney function goes downhill. So, I mean, think about this. We have really good ways to prevent the progression of kidney disease, to prevent or delay dialysis or transplantation. And I personally never want to be on dialysis. You talk about being tethered and going in. If you need it, you need it. And for those of you on dialysis, God bless you. Hang in there.
Yeah, absolutely. But these medications, I think when I talk to patients a lot, I feel like oftentimes people are scared of these new medications because they all tend to have some side effects associated with them. We talked about the nausea with the GLP-1s. Every medication that you could take is going to have a potential side effect. But this is the first time, at least in my medical career, as long as I can remember, that these medications, I mean, the benefits are so much farther higher than the risks. They should be in the water as far as I'm concerned.
Yeah.
I mean, they're really that good. And the downsides of not taking them sounds riskier to me. Being on dialysis, having a heart attack, having a stroke, these sorts of things. I think that is way riskier than, some of the side effects that are associated with them.
Yeah, we all have to decide the risk-benefit ratio, but I totally agree with you. The benefits are just tremendous. First time in my career, I've seen such powerful medications with very low side effects. And I probably prescribed more of the Farxiga and Jardiance than my kidney doctor did for a while because they were a little more cautious. But the data on preserving the kidneys is tremendous.
Truly, yeah. Okay, here's a question that I think we can kind of have a few comments on. I have spent many hours and money with functional medicine specialists who claim the only way to bring your diabetes into remission, type 2 diabetes into remission, is to have expensive specialized laboratory testing to find the root cause. Is this absolutely necessary? And I think this is such an important question, and I'll broaden it out a little bit. But these days, with the amount of information that we have available on the internet and AI and everything out there, it's information overload. And I think that there's a lot out there that people can be maybe convinced of is either helpful for their diabetes or they need certain tests, in order to have good control of their diabetes. And I think it's important for us to kind of debunk that.
Well, well before the internet, there's a lot of scams out there. That's all I could say, plain and simple. And even in the early 1920s, when people were dying, insulin was not discovered yet. People were selling insulin tonic in bottles, and people are desperate. For all of you that have bought supplements that help diabetes, cinnamon, those Cinnabons don't help your diabetes at all. Bring back an old classic joke, but I was at Costco the other day and they had special vitamins for people with diabetes.
Yeah.
And nothing against functional medicine. Some of the things they do, I believe in, but the way this question came in, I would just say it's a scam, and they charge a lot for everything they do. And I like to stick to proven methods. Now, I could be old-fashioned, and you might be a supplement person. God bless you. Your urine's probably all kinds of shades of color, but I'm kind of against that personally.
Yeah, I agree. I used to have patients all the time coming in saying, giving me a long list of supplements or what they were taking and asking, will these supplements help my diabetes? And I'm not a supplement expert. So, I would always tell them that. But then I would always say, what do the shelves look like at GNC or Sprouts or Whole Foods where all the supplements are? And they're generally stocked full with many different brands of the same supplement, right? And I said, if something is going to be a miracle treatment of your diabetes, it's probably going to be flying off the shelves. And do you know what has flown off the shelves? The GLP-1s. I mean, truly. The GLP-1s, Ozempic, Trulicity, Mounjaro, they flew off the shelves because they work so well, so quickly that the pharmacies couldn't even restock them.
The shortage for a while.
Shortages. I mean, it was hard for us to prescribe them. So, just keep that in mind. If there's a miracle drug out there or a miracle supplement, you will know it.
Yeah. I should mention that for those of you concerned about getting them and paying for them, a lot of my patients go to Mexico. They get the real deal. It's from Lilly. It's from Novo. The writing's in Spanish, and it's about a quarter of the price or less. And both Lilly and Novo have a discounted on their website. You can get it directly from them.
Yes.
And that's good to know. But stay away from compounding pharmacies. Now that both companies make enough Ozempic, Mounjaro, the compounding pharmacies are disallowed. So they're illegal now. There's been a bunch of hospitalizations. I don't want to scare people, but there's been a few deaths. And as Dr. Santos said earlier, you don't know what you're getting in these formulas. And I understand it. I would really want this too if I had weight problems, diabetes problems, all the issues that people with type 2 have. And I think it's got to be one of the most important class of medications. And I would do anything to get it too.
For sure. Okay, I want to change subjects here a little bit. And this is kind of moving a little more over to the touchy-feely side of diabetes. But there's a question here that says, as someone without diabetes, how can I help a family member in denial about their type 2 diabetes, especially when it comes to obesity and GLPs?
Wow, that's a tough question. We get that all the time.
Yeah.
Family members, they care about their loved ones so much. And sometimes they feel like their loved one is just not taking care of themselves, eating wrongly. And that's especially true in type 2 diabetes, because they see that their loved one is overweight. They've gotten overweight from bad habits. It's I'll let you go first because I can't think of anything right now.
Yeah, I mean, I'll say we see both sides of this. So to broaden it out a little bit, we see loved ones who have family members who are in denial. And then we see kind of the other side of things where, the person with diabetes is doing fine, but the loved ones are kind of going over the top on everything. And so, my suggestion would be to come at your loved ones from a place of love, being loving and caring, which sounds kind of cheesy, but truly coming from that angle rather than coming from the angle of being kind of harsh and a critic and judgy. I think that a little bit of TLC and showing that you care kind of goes farther than kind of being the hammer.
Yeah, this is a perfect time to do a great shout out to Bill Polonsky, probably one of the world's experts on the emotional and behavioral issues of diabetes. We just did some content with Bill. It's excellent. We did short form. We did reels.
The podcast I just listened to was really good.
We did a podcast with him just recently.
Yep.
And there's also several lectures by him in our video vault. And what he would say is just what you said, have some empathy for your loved ones. And I can just see him saying this now. Ask them the best way they can help.
Yeah.
And do not tell them what to do or how to do it, because he calls all your folks relatives the diabetes police. So I think it has to be empathy, and like you said, do not be bossy and just ask how you can help and sympathize.
Yeah, agree. All right. This next question says, it's pretty simple, but it's a big question. Is there a cure for type 2 diabetes? I know we talk a lot about a potential cure for type 1 diabetes. What about type 2 diabetes? I think this is in some ways even more complex.
It is definitely more complex. Type 1 is an autoimmune condition. So you can really focus your research on how do you prevent the autoimmune attack from starting, and once it started in the early stages, how to halt it in its steps, and without using immunosuppressants. So that's type 1. It's a fairly narrow area of research, but in type 2, I mean, Tricia, I did my fellowship at UCSD. I started way back in early
100
19
years ago.
Yeah, 100 years ago, 1987. And that's when most of the research was being done. Type 2 is caused by insulin resistance, and that's a very complicated mechanistic abnormality. It's multiple genes that have been shown to be abnormal. We really don't know the cause of type 2 diabetes after all these years.
Yeah. It's so complex. I think the answer to that is, we don't see a cure in the near future. Some people with type 2 diabetes can go into remission with some lifestyle changes, but I'm always cautious saying that, because one thing that I think is really important to know if you have type 2 diabetes is that it is a progressive disease. And the reason that's important to know is you could be doing everything right. You could be taking your medication. You could be as you're supposed to. You could be, starting new medications when your doctor adds one on. You could be making lifestyle changes. You could be losing weight. And the diabetes may still continue to progress. You may still need insulin down the road. You may still need additional medications. And that's not your fault. It's just the nature of the disease.
Yeah. What's interesting is that as they're trying to discover what causes type 2 diabetes, they have found many abnormalities. So I've mentioned insulin resistance. So we have insulin sensitizers like metformin and drugs like pioglitazone, and even drugs like GLP-1 help a little bit. Then we discovered that in type 2 diabetes, you're not getting rid of the glucose in your blood well enough. So that's when they came up with Farxiga and Jardiance, which push excess sugar into your blood. And then they came up with the fact that there's not enough GLP-1 in your blood, which helps with lots of things, including appetite. So they came up with GLP-1 receptor agonist. That just means it stimulates those receptors. So almost every defect we found in type 2 diabetes, at least we've developed a medication to help that. And that's why when you treat type 2 diabetes, it's a polypharmacy condition. Yeah. And you know what? It's so funny. At these big medical meetings, let's say the American Diabetes Association, which is the biggest meeting in the world, I don't really see much on investigating the cause of type 2 diabetes.
Or a cure. Yeah.
Or a cure.
Yeah.
And so I think the best thing to do until there's a cure is take care of yourself, and not just your glucose, but your weight, your blood pressure, your cholesterol levels. And, you can live a long and healthy life, and in fact, longer than other people of the same age, weight, and sex.
For sure. Yeah. And I do think, I just want to hammer in, there were a few questions on metformin here. And, metformin used to be the first medication that we use to treat type 2 diabetes. And there has been a shift in the last few years where now really our guidelines are telling us to start an SGLT2 and a GLP-1 before metformin even. Metformin is still a great drug, great medication for type 2 diabetes. But I think that, really understanding the fact that focusing less on a cure and getting rid of the diabetes and really focusing on how to manage it and getting all the benefits out of these medications for your heart and kidneys and other things, I think is the way to go.
Yeah. Most doctors, I would say primary care doctors and even endos, they take the path of least resistance. It's so easy to start metformin. They're used to doing it. It's oral, it's generic. And then to start something that may have some resistance with your insurance company, it's not bad to start with metformin and then a quick second.
Yeah.
But you're right. The American Diabetes Association says if you have issues with weight, heart, kidneys, and the heart could be congestive heart failure, prior heart attack or stroke, peripheral vascular disease in your lower extremities, then you should start these medications first. And I'm hoping that they become easier to prescribe, easier to get. And I haven't had too many issues with the Farxiga and Jardiance.
No, they're much easier to get approved now. Even a lot of the GLPs, things are getting better for sure.
Yeah. So things are getting better.
All right. Well, we are running out of time. Wow, that went fast.
Yeah.
I do want to remind everyone, here at TCOID, there's so much wonderful content, not only with these lives, but on the website. As Steve mentioned, there's all these video vaults, there's, short films, there's podcasts, there's a wealth of information for you. This is a nonprofit organization, so all of that is coming to you for free. But it does cost money to produce. So if you feel inclined to donate, please hit that donate button, which should be up there on the Q&A live. We also have a donate button on the TCOID website as well.
Thank you, Tricia.
Yeah.
Appreciate that. And remember, if this will be on a little later, in case you want to listen to it again, have your friends listen to it. Make sure you go to the different social media sites, look for us, especially Facebook and Instagram. Don't forget YouTube, LinkedIn, X, and my big joke is Tinder. And so it works every time. And thank you so much. And we'll see you the next time we do a live Q&A.
Thanks, everyone.
Okay. Thanks, Trish.